Hello, my name is Vikas Agrawal. I'm a neuroradiologist at the University of Pittsburgh Medical Center in Pittsburgh, Pennsylvania, and today I'll be talking to you about spine infections. Our objectives are to review the imaging appearance of spine infections, to understand some of the clinical manifestations that go along with spine infections, and then also recognize some important mimics of spine infections. Spine infections are a critical diagnosis. Early identification and directed treatment are paramount. Delay or misdiagnosis can lead to profound neurologic deficits, structural deformities, and increased morbidity and mortality. There's additional importance for recognizing spinal infections given the close proximity of the spinal cord, aorta, and the mediastinum, and therefore their potential for multiple compartments to be involved. It's a challenging imaging diagnosis with many non-infectious mimics, and therefore the radiologist has a crucial role in helping our clinical colleagues. I think it's important to think of infections as they relate to compartments in a similar way as we organize differentials for compartments in the spinal canal, so intramedullary, intradural, extramedullary, or extradural. In this case, I've categorized infections in the spine based on the anatomic structures that are involved. So there are things that involve the spinal cord, things that involve the meninges, as well as the vertebral bodies and disc spaces. You'll see I've kept post-operative infections off to the side here as a special category only because it can involve multiple compartments. Let's take a look at our first case. This is a 54-year-old male with a history of low back pain. Give everybody a few seconds to take in the images. We've got T1 images, T2 images, and T1 post-contrast images. So what we see are areas of end plate erosion on the T1 weighted images with bone marrow edema on both sides of the disc, as indicated by the yellow arrows here. There's low T1 signal, high T2 signal, and then enhancement. We have an abnormal configuration of the disc space. We've lost height, and as well as have T2 signal and enhancement in the disc space. In this case, there is some epidural enhancement here, suggesting that there's a developing epidural abscess. So this is the classic imaging appearance of pyogenic spondylitis or spondylodiscitis. There can be involvement of the paraspinal soft tissues, as I've indicated here with the yellow arrows, and this has been termed the psoas sign. So this is T2 hyperintensity with loss of the fat plane between the psoas muscle and the intervertebral disc space. Psoas abscesses can develop here in the red arrow, but is usually a delayed manifestation. We tend to see involvement of the psoas muscle earlier than the additional paraspinal soft tissue involvement. Here's another case. This is in the thoracic spine. We see those same findings a little bit more earlier in the course of the infection. You see end plate changes, you see some marrow edema, you see abnormal signal in the disc space itself, some prevertebral soft tissue swelling. Here on the axial image, you can see that same idea of the psoas sign, but extended to the thoracic spine, where you lose the fat plane between the paraspinal soft tissues and the intervertebral disc and vertebral body. This is very good diagnosis for spondylodiscitis, pyogenic spondylitis or spondylodiscitis. So we talk about the psoas sign. This is a reference from the group at the University of Utah who published this in AJNR in 2016, and this is where they actually describe the psoas sign as being one of the best signs for evaluating early spinal infection. Lumbar spine is the most common location for spondylitis, spondylodiscitis, with over half the cases found in the lumbar spine. This is a hematogenous spread of infection with septic emboli, most commonly arising in the GU tract, the skin, or in the respiratory tract. And so the idea is that there's deposition of microemboli into the metaphyseal artery, which then results in infarct and subsequent infection. So you can see here the vertebral body has a very rich blood supply all the way out to the end plate, and so these microemboli lodge here at the end arteries in the end plate, and this is where you end up with infarct and then subsequently infection. The disc space itself here is nearly avascular in adults, so there's no defense mechanism to stop the spread of infection, so you can see how the infection can spread through the disc space from one end plate to the next. as you noted here through the contiguous vertebral bodies. In children, there's a much more redundant blood supply, so there's not as many end arteries here at the end plate, and so that only a small infarct develops, and therefore you don't really get as much infection spreading from the end plate to the disc and to the other side. The other mechanism for infection in the lumbar spine is through direct extension in the setting of either penetrating trauma, recent surgery, or an adjacent infection, for example, in the lung or the oropharynx. Clinically, these patients tend to have complex comorbidities, including diabetes. They may be immunosuppressed, maybe on long-term steroid use. They may be smokers. They may have had recent prior surgery. And then I've put intravenous drug use as a separate category here because we are seeing so much more of this now in our daily practice over the past several years, where we're seeing much more discitis osteomyelitis in the setting of IV drug use. Patients will typically present with focal back pain. They may have myalgias, muscle spasm, depending on whether or not the neural foramen is involved. They may have radiculopathy. Clinically, they will present with fevers, elevated white blood count, and they'll have elevated ESR and C-reactive protein, so their inflammatory markers are going to be elevated. Blood cultures are positive in about a fourth of cases, so a good indication for us to do a biopsy is in a patient with imaging findings and clinical findings suggestive of infection, but a negative blood culture. In that case, it may be prudent for us to do an image-guided biopsy to try and establish the infection. The majority of these tend to be Staph aureus, but we do see E. coli as the most common gram-negative source, Pseudomonas seen in IV drug users, and then Salmonella in sickle cell patients. Here's another example of a patient with infection centered at L3-4. This is a 34-year-old male with several weeks of low back pain, found to have imaging findings of discitis osteomyelitis and a ventral epidural abscess, as seen by the red arrow on CT, on the contrast-enhanced MR image. On CT, we can see that destruction of the end plates, and it really helps us start to think about infection in this case, given the degree of end plate destruction. And CT can also then be used for image guidance if tissue sampling is pursued. In this case, this is exactly what we did. This is my biopsy needle going in to sample the disc space. I've outlined the exiting nerve here in yellow because we want to make sure we don't damage the nerve. In this case, this culture came back as Staph aureus, methicillin-sensitive Staph aureus, MSSA. Here's another example in the thoracic spine. This is a 59-year-old male with 2 months of mid-thoracic back pain. He's got imaging findings of discitis osteomyelitis at T8, T9 with an abscess. Again, you see that end plate irregularity, marrow edema and enhancement, abnormal configuration of the disc space, and then the epidural collection developing here. In this case, this culture was Staph aureus, methicillin-resistant Staph aureus. So let's change gears here and talk about an important mimic for pyogenic spondylodiscitis, and that's degenerative disc disease. Oftentimes these two can have a similar imaging appearance, and it can be a diagnostic dilemma to determine which entity you're dealing with, because the treatment is very different for the two entities. So degenerative disc disease, the first thing to look about is that there's not that degree of end plate erosion or cortical destruction. The T1 weighted image on MR is very helpful, and you can see in this case the end plate is not overtly destroyed. In this case on the CT, again, you can see the end plate is intact. The vacuum in the disc space is very rarely seen with infection, so you can see some locules of nitrogen gas here in the disc space. So very rarely do we see vacuum phenomenon in an infected disc space. And then these patients typically don't have the paraspinal soft tissue findings that we talk about with pyogenic spondylodiscitis, so-called SOAS sign. So here's the axial image that goes with this patient, and you can see the fat planes in the paravertebral and the prevertebral soft tissues are well preserved. I can see the fat here very nicely. I can make out the psoas muscle and the margins of the psoas muscle. There's no infiltration of this fat here in the margin of the disc space and end plate. The other thing that is another sign that can be used is something called the claw sign. And so the claw sign is identified on the diffusion-weighted imaging. It's a well-marginated, linear, typically paired region of high signal situated in the adjoining vertebral bodies at the boundaries between normal bone marrow and vascularized bone marrow. So here, as an example, you can see this T1 hypointensity involving the end plate superiorly and inferiorly across the disc space here. There's a little bit of T2 signal here that you can see, and when you do the diffusion-weighted image, you can see this area of increased signal on the diffusion, almost in a claw-like format here with an open mouth claw format. Here's the schematic from the AJNR article, and again, you can see that granulation tissue and edema in the end plate, and then there's that diffusion claw sign. This is the reference from where these images were pulled. I would recommend that everybody take a look at this article. This was from 2014, and they found that the diffusion-weighted MR claw signal really helped identify modic type 1 signal changes rather than infection. So let's sum that up here. So let's take a look at these two cases. We've got the first case on the top and the second case on the bottom, and the question is it infection or degenerative? And so the three things that I like to look at, the first is the end plate and end plate irregularity. Is it well-defined or ill-defined? And I think the best sequences to do that are on MR is the T1 weighted sequence, and on in CT it's the bone window in the sagittal plane. So notice here in this case the end plate is very ill-defined at this level, as opposed to here where I can still take a pencil and draw where the end plate exists. On CT, same thing, the end plate is destroyed here or ill-defined, as here the end plate is intact and still able to be traced out. So this would argue for infection, this would argue for degenerative disease. The second is the psoas sign or paravertebral soft tissue infiltration. Here you've lost the fat plane on this T2 weighted image between the disc space and the psoas muscle. You've got infiltration of the psoas muscle on each side. In this case, you have a very nice, well-preserved fat plane between the psoas muscle and the margin of the disc space and end plate. So infection, degenerative disease. And the third way to differentiate this is really the claw sign. We don't routinely do diffusion-weighted imaging with all of our lumbar spine MRs. Some places do. We may add that sequence in cases of suspected infection. And so remember, a diffusion sign, high diffusion signal in a claw-like formation here is very suggestive of degenerative disease rather than infection. Let's look at our second case. This is a 61-year-old male who has a history of IV drug use, presents with low back pain, right side more than the left side. So we've got T1 post-contrast, sagittal and axial, and then an axial T2 weighted image. Give everybody a few seconds to look at those images. And so what do we see here? So we see a large dorsal epidural abscess centered at the L5-S1 level. So here the yellow arrow pointing to an enhancing epidural collection in the dorsal epidural space extends both cranial and caudal from the L5-S1 level, sort of where the epicenter is. On the axial T2 and post-contrast images, you see this very abnormal appearing facet joint here on the right at L5-S1 compared to the left. You see surrounding T2 signal in the paraspinal soft tissues and musculature. All of that is demonstrating enhancement and edema, and you can see this extends into the neural foramen as well as the dorsolateral epidural space, and this is that dorsal epidural collection abscess that we're seeing on the sagittal images. And so this is a septic facet joint. Some people will refer to this as facetitis. And so the key here is if you see a dorsal epidural abscess, you always want to make sure that you take a look at the facet joints. So ventral epidural abscess, think about disc space infection. If you see a dorsal epidural abscess, think about infection starting in the facet joint or a septic facet joint. In this case, we did sample this, and the organism was a group B streptococcus. This is an increasing disease entity that we see a lot more of now with IV drug users. We're seeing a lot more septic facet joints in these patients, and we're being asked to sample the facet joint to help identify an organism. Let's take a look at this case. This is a 43-year-old male with fever and low back pain. And we've got sagittal T2 weighted images, a coronal stir, and then an axial post-contrast image through the upper lumbar spine. Give people a couple of seconds to look at those images. Okay, so the yellow arrows show us the bone marrow edema on both sides of the disc space here, a lot of high T2 signal on both ends of the vertebral body straddling that disc space, so low T1, high T2, and then enhancement. If you notice, compared to the other case we saw in the first example, the disc space is relatively well preserved. There's no significant loss of disc height. There's no abnormal T2 hyperintensity within this disc. And even on the coronal stir, you can see the disc space are relatively well preserved. If you take a look at the axial image, you'll see that there's anterolateral involvement of the paraspinal and paravertebral soft tissues here, noted by the red arrow. So it's lateral and then extends anteriorly. So this is a very good look for tuberculous spondylitis, spondylodiscitis, or TB in the spine. So here's a couple of more examples. Again, you can see that this is spreading anterolaterally with peripheral enhancement of the surrounding osseous structure. So you can see all of this enhancement in the anterolateral space, sort of rim enhancing involvement. The disc space here, again, not as well involved at all. In late cases, you can certainly see involvement of the disc space, but in early cases, the disc space is relatively preserved. And this is one of those clues of TB, is that you have involvement anterolaterally with skip involvement of vertebral bodies. So you can see how this infection is starting here and sort of creeping up, but not really involving the disc, but going up through the paravertebral and anterolateral soft tissues. Long-term sequelae of spinal TB, so-called Pott's disease, is development of a focal kyphosis, or so-called gibbous deformity. So this is an example of a patient that we saw a few years back, a young woman who was originally from Haiti and had developed TB as a child, and now had started having some difficulty with balance and gait. And the myelogram here shows this very nicely. I've labeled this as the T2 vertebral body and the T12 vertebral body. Between T3 and T11, she has collapsed and formed one conglomerate vertebral body. You can see all the posterior elements here sort of conglomerating in one big bone mass here, and this focal kyphotic deformity with kink of the spinal cord. So in tuberculosis, we still, the prevalence is declining, but we still see it in immunocompromised patients, in homeless patients, and sometimes in the developing countries. Patients typically have a low-grade fever, but it's a much more insidious onset of symptoms compared with pyogenic spondylitis, spondylodiscitis. The organism is obviously Mycobacterium tuberculosis, typically tends to involve the thoracolumbar junction, begins in the anterior aspect of the vertebral body and spares the disc. It spreads in a subligamentous fashion deep to the ALL, which allows it to traverse multiple levels, spreading anterolaterally. And interesting to know that the actual organism, Mycobacterium tuberculosis, lacks the proteolytic enzyme to break down the disc, and so this may be one reason why the infection spreads around the disc instead of through the disc. Let's take a look at this case. This is a 37-year-old female who is having neck pain. She has a history of IV drug abuse, and her neck pain has been present for several months and has become so severe and debilitating that she now requires hospitalization. So we've got T2 weighted images here, T1 post-contrast, sagittal and axial. Okay, so the yellow arrow in the image here shows us bone marrow edema on both sides of the disc space. If I had a T1 image to show you, it would show that same low T1 signal, high T2 signal. But if you think about the examples that we saw for discitis, osteomyelitis, the pyogenic kind, or even the tuberculous kind, you can notice that the marrow edema in the vertebral bodies is actually relatively less, as well as the enhancement is not as profound in the end plates here. And then there's not as much osseous destruction here. So one could argue that you could take your mouse pointer here and still follow the end plate here. There is abnormal configuration of the disc space. There's T2 hyperintensity within the disc space. There's some enhancement along the margins of the disc space. And then certainly there's involvement of the paraspinal soft tissues, in this case with an epidural abscess developing in the ventral epidural space. So this is a good look for fungal spondylitis or spondylodiscitis. And the key here is that these are typically immunocompromised patients. They may have HIV, bad or poorly controlled diabetes. They may be patients receiving chemotherapy. Or in our institution, we have a large segment of patients who are post-transplant. And as transplants increase around the world, they're increasing incidence of fungal-related infections. These patients, similar to TB patients, will have low-grade fever. They'll have an insidious onset of symptoms. And typically the organisms tend to be Candida and Aspergillus. And so the key here in trying to at least include fungal in your differential is that the imaging findings may reflect the blunted immune response. So these patients may not be able to mount a significant immune response, and therefore they may have less T2 hyperintensity and edema of the end plates, less enhancement of the end plates, and less destruction because they're not able to mount that immune response. Let's move on to the next case. So this is a 27-year-old female presenting with paralysis. And so we've got T2 stir, T1 post-contrast, and then an axial T2 weighted image. So we have a long segment cord involvement. So there's long segment cord signal abnormality here extending from the mid C2 level to at least the C6 level. The cord is expanded. You can see the expansion of the cord compared to down here in the lower cervical upper thoracic cord. There's contiguous, predominantly central T2 hyperintensity here. So on the axial images, we can see that there's greater than 2/3 cross-sectional involvement of the spinal cord. And then there's this patchy areas of enhancement on the post-contrast images here delineated by the red arrow. And so this is a good example of transverse myelitis. And so transverse myelitis is an insult to the spinal cord, either through direct viral infection or through additional etiologies such as post-vaccination, paraneoplastic syndromes, or in some cases an idiopathic etiology. These patients tend to present with an acute onset of weakness following a febrile illness. The patients tend to be younger or immunocompromised, and they go from having bilateral lower extremity paresthesias progressing to paraplegia with or without bowel bladder dysfunction. These patients have a rapid progression with neurologic impairment within days. And have a variable prognosis. Despite steroid and antiviral therapy, a third of these patients will have poor recovery. Organisms that tend to be involved are enteroviruses, influenza, CMV, HSV, HZV, and immunocompromised patients. Sometimes it may not always get a definite organism from the CSF, but in most cases the CSF is positive. You may want to consider imaging the brain as well, just to make sure you're not having additional complications in the brain. An important mimic to think about in these patients with transverse myelitis is a spinal cord infarct. And without getting into too much details about the spinal vascular anatomy of the spinal cord, it's important to remember that spinal cord infarcts present as long segment spinal cord expansion, as noted here on the T2 weighted image, with diffuse T2 hyperintensity and very minimal, if any, enhancement. The DWI tends to be positive in these patients, and you get that characteristic butterfly signal abnormality in the spinal cord on your T2 weighted images. This is an example of an elderly patient who had significant vascular disease, who had rapid progressive paraplegia and urinary retention, and this patient had a spinal cord infarct. This case is a 22-year-old male presenting with headache and neck pain. T2 weighted images, T1 post-contrast images, T1 pre- and post-contrast axial images. Give everybody a second to look at that. And so what we see in this case is smooth meningeal enhancement here along the dorsal surface of the spinal cord, but also all of these distal nerve roots are showing very smooth enhancement here on the T1 pre and then the post-contrast images. There may be focal or diffuse spinal cord swelling. In this case, the spinal cord appears, what we see of the spinal cord appears normal. And the CSF may show T1 hyperintensity. In this case, the CSF is appearing normal on the T1 post-contrast images. But these are findings that can all be seen in the setting of meningitis. And so meningitis, we have to remember, is an important diagnosis that typically is made by CSF sampling, but in some cases on imaging we can see examples of meningitis. This is an infection of the leptomeninges in the subarachnoid space. These patients typically, if they have a bacterial etiology, will have acute onset of symptoms. If they have a subacute onset of symptoms, then it tends to favor more of a viral etiology. Important to recognize that imaging can be negative early in the course of these patients, both brain and spine, but that the CSF tends to be positive, and that important to start antiviral or antimicrobial therapy early to improve clinical outcomes in these patients. The mimic here that you want to remember is Leptomeningeal Carcinomatosis. And so this is a 60-year-old woman with a history of breast cancer. And you can see on the post-contrast T1 images through the cervical, thoracic, and upper lumbar spine, you see a diffuse thick sheet coating of the spinal cord. You can see these multifocal areas of discrete enhancement in a nodular type fashion along the surface of the cord here, as well as along the nerve roots more distally here. And then again, that diffuse thick sheet-like coating of the spinal cord. And so CSF dissemination or leptomeningeal carcinomatosis, we see that in CNS primary cancers, but also in systemic therapies, most commonly breast and lung, just because those are more common cancers that we see. These patients, despite treatment with radiation therapy or chemotherapy, tend to have a poorer prognosis. So important to remember leptomeningeal carcinomatosis in your differential. This is going to be our last case. This is a 52-year-old male who presents with postoperative fevers. And so we've got sagittal T2, sagittal T1 post-contrast, and axial T1 post-contrast images. No surprise here, this is a case of postoperative infection, as the clinical history would suggest. On the T2 weighted images, you can see involvement of multi-compartments. You can see fluid deep to the skin incision that extends into the laminectomy bed, in this case causing a large amount of mass effect on the dorsal aspect of the thecal sac. You can see all of the enhancement on the post-contrast images here on the axial and sagittal images delineated by the red arrows. You can see a fluid collection here, a fluid collection here. You can see the thecal sac is compressed. And so important to remember involvement of multi-compartments depending on the extent of infection. These patients may have abscesses, phlegmons, fluid collections within the surgical area, and compression of the thecal sac or nerve root compression. And so depending on the different compartments involved, if this is able to spread more anteriorly, these patients can develop meningitis, they can develop discitis, osteomyelitis, and therefore be extremely symptomatic very quickly and decompensate quickly if not recognized early. So postoperative infections, the incidence is about 2 to 6%. Patients will typically present with fever, pain, erythema, wound drainage, with elevated white count and elevated inflammatory markers. Important to recognize that infection can happen in the acute setting, so within 30 days of surgery, likely related to direct contamination. And in these cases, the CRP is one of the most sensitive indicators because it will peak on the second or third day of infection, second or third day postoperatively, but then return to normal by 14 to 21 days. And so if you have a persistently elevated CRP, it may be a clue that you're dealing with a postoperative infection in the acute setting. You can get delayed infections 10 to 12 months out from your surgery, and these findings are thought to be related to hematogenous seeding or even a sterile inflammatory response to hardware if present, which allows a low virulence organism to start to fester. And so it's also important that in the early postoperative time point, enhancement of lumbar nerve roots can be seen in 20% of patients who don't have any symptoms, and then can persist up to 6 months, with still 2% of patients showing lumbar nerve root enhancement. So important to note that the normal postoperative changes can be indistinguishable from infection, and so really important to correlate with the clinical symptoms and laboratory markers, and to have a discussion with the surgeon who's caring for that patient to recognize whether or not you're truly dealing with an infection. So in summary, spinal infections are increasing. The radiologist plays a critical role in both imaging and tissue sampling. MRI is the modality of choice for imaging spine infection, and contrast should be utilized when possible. Pyogenic spondylodiscitis is centered around a disc space. Care should be taken to try and differentiate imaging appearance from end plate degenerative changes. So remember integrity of the end plate either on your T1 weighted images or your CT. The psoas sign, or the involvement of the paraspinal soft tissues, and then the claw sign if you're getting routine diffusion weighted imaging or adding diffusion weighted imaging to your MR protocol when evaluating infection. TB spondylitis can be suggested based on the characteristic imaging features. So remember, it's sparing of the disc space, traveling anterolaterally to skip segments of vertebral bodies. And important, especially in the context of recent surgery, to take clinical information in conjunction with imaging findings in order to make an appropriate diagnosis and direct treatment. Thank you.